Thank you for tuning in this week. This is Dr. Dillon Caswell, the host. Today's episode, we are in part 2 of a 2-part series on the sacroiliac joint. Today, we're going to be discussing what can actually create or what is the cause of sacroiliac joint discomfort. How do we rule it in? And then most importantly, what are the solutions available? How do we start to treat it? Is it exercise? What are our thoughts on sacroiliac joint belts? It's a great episode. We hope you enjoy it. Today's show is sponsored by the Prehab app. This is not just an app, but a solution. You have the opportunity to take control of your rehab, prehab, fitness, and performance needs all from the palm of your hand. The app is available for download on the App Store for both Apple and Android users. Also, a free 7-day trial is available. Don't wait. Start taking control of your movement health today. You don't want to look like the picture of health on the outside, but have no idea what's happening on the inside. Our podcast sponsor, InsideTracker, is here to help. It was created by experts in aging, genetics, and biometrics from Harvard, Tufts, and MIT. InsideTracker provides personalized health analysis and clear recommendations from 44 tested biomarkers, plus an action plan on how to make changes to live a healthier and longer life. Along with accepting nearly all forms of payment, you can use your HSA, HRA, and FSA to buy any InsideTracker plan, and for a limited time, you will get 20% off the entire store when using the code PREHAB. You can visit the website by visiting InsideTracker.com/prehab or check the link down in the show notes. Go and check out a plan, enjoy 20% off, and start optimizing your health from the inside out. Prehabbers, welcome back to the show. This is part 2 of that 2-part series on this important joint, the sacroiliac joints. Part 1, if you haven't listened to that, episode 159, pause this and go visit that episode first, then come back to this one. But a quick recap, we talked about how strong and how resilient the sacroiliac joint truly is, and this narrative surrounding it that the SI joint is out and this maneuver or technique is putting it back in. Why that is just complete rubbish. I like using that word now, rubbish. I think it might be my new word. But anyway, it needs to change. That narrative needs to change because it's not the truth. It's not what's happening. It's creating fear in people. But with that being said, we ended the episode with some newer research that challenged some of our own beliefs that the hormone relaxin during pregnancy creates ligament laxity, and that ligament laxity is then associated to the pain and disability specific to a pregnant population. The research is showing that that's not the case, but the sacroiliac joints can be a source of pain. They can be a source of discomfort. That's what we're going to dive into in this episode is then what is creating these symptoms? And then how do we actually rule in that it's a sacroiliac joint? And then lastly, how do we start to solve it? Because if you're dealing with sacroiliac joint pain, there are solutions. And what we're going to find is that we really need to start with the simple solutions first, instead of going to some invasive procedures that are out there. So to kick this off, I'm going to share a quick story with you. A few weeks ago, I had the realization that I can save electricity if I am charging my phone in my car while I'm driving. So I have a little bit of an older CD deck, has a USB port connected to it, aux cord, does CD, Bluetooth, radio, but I plug in this cord to then charge my phone as I'm driving. And it was great for a couple weeks. And then my CD decks just started completely tripping out. I'd be on Bluetooth and it would randomly just go to the CD. And then from CD, it would randomly go to radio. And then it would just keep switching. No rhyme or reason to this. It was really confusing. It was pretty annoying to be honest. And I was like, dang, I need to fix this because I cannot continue to drive like this, or maybe just go to silence. But that's typically when I'm listening to podcasts or music. And I like having that little bit of stimulus as I'm driving. So I'm like, okay, I need to fix this. What's the issue here? My brain immediately went to the most complex thing. It's the wiring harness. I need to take the deck out, need to redo the wiring harness, and that will solve it. That'll take care of the issue. But then I realized I'm making a crucial mistake. I need to pause. I need to take that step back. I need to reflect and say, what has changed in these past few weeks that may describe this behavior that is occurring? So in doing that, I realized that the only thing that's changed is now there's a cord that's plugged into the USB port. So I look at that cord and the end of this cord was absolutely fried. It was corroded. I made the mistake of leaving it plugged in when it wasn't plugged into the phone. So electricity was running through it and the cord just completely, it was just blown out. I unplugged that cord and the problem was solved. The CD deck is back to working normal. If it's on Bluetooth, it stays on Bluetooth. If it's on the radio, it stays on the radio. And what I learned is that we tend to jump to these rational conclusions that it's complex. There's something really, really complex that's creating this. And when we take that step back and really look at simple solutions, we look at pattern recognition, that really starts to give us better solutions. And that's what's going to happen as we go through the sacroiliac joint. So the first place to start with this is that if it is the sacroiliac joint in question, we need to rule out everything else. And then once we do that, we find simple solutions. So the lumbar spine is key. The lumbar spine can refer symptoms down to the sacroiliac joint, where the sacroiliac joint doesn't necessarily refer symptoms up to the lower back. Let me say that again because it is so important. Researchers in this area, Vanderwerf, Laslett, have done multiple research studies on this area and have found that it is important that we know this, that low back pain, whether it's lumbar spine disc herniation, spinal stenosis, a QL strain, whatever may be happening in the lower back, that can refer symptoms down to the sacroiliac joints and down the rest of the leg. But the sacroiliac joint does not refer its discomfort up to the lower back. It may refer to the groin and the buttocks. And this is such an important point because that little piece of information lets you know how important it is to do a full screen and to rule out lumbar spine. And I'm going to add in hip, rule out the hip first, lumbar spine and hip. And then we can start looking further into the sacroiliac joints if those tests are negative. There's research showing that if somebody has discogenic pain with radicular symptoms, which we did an episode on, is disc movement predictable and what does it mean of peripheralization and centralization? So if these words are new to you, go ahead and listen back to that episode. But research, again, by Laslett has found that if a person's symptoms can be centralized through movement, that it changes the outcome of the special test for the sacroiliac joint, meaning that if you go right in and just start testing the sacroiliac joint without ruling out these other things, you end up with a bunch of false positives. You end up trying to do solutions for something that you don't really know what's happening with it. So make sure you rule these things out first and that you're not getting caught in that trap and you're not getting these false positives because you didn't rule out the other factors first. Another factor that we need to talk about and bring to light, especially in this area of SI joint pain and pelvic girdle pain, because remember, the sacrum is the center of our movement system, right? The ilium is coming over and connecting into this. The lumbar spine is coming down and attaching into the sacrum. The sacrum is our base, but from the ilium that connects to the sacrum, this is going to come out and then wrap around in front to form the whole pelvic girdle. What's inside the pelvic girdle? Our pelvic organs, our pelvic floor muscles, a lot of very important structures. With that being said, we have to keep in mind that sacroiliac joint pain or pelvic pain in general, this can be created from non-musculoskeletal causes. There may have been an event that happened, right? There might have been something horrific that happened, like sexual abuse or something along those lines, something horrific that the body intuitively has had trauma and it's trying to protect that area. And rightfully so. It doesn't trust the environment. Why would the body trust the environment after something like that? So we have to be open. We have to set up safe environments where if people are feeling safe and they're going to honor us with this story and this information, we need to be open to listen to it and then open to get them into the right hands that's going to help them through that issue if that does come up. But important to know that sexual abuse, pelvic floor dysfunction, that this can create what is disguised as sacroiliac joint pain. So there's a lot of factors that could be leading into this. We just need to make sure that if we're going down this road and we're looking at movement solutions, that we are understanding what is creating this discomfort in the first place. So in the subjective history, there is actually 3 things that come up that really help us to identify that we should move further with sacroiliac joint special testing. These 3 factors, what are they? They are groin pain, sacral sulcus tenderness, and if you have PSIS discomfort, or you point to the PSIS and say that it's sore there, or the sacral sulcus or groin pain, if those 3 things are said, we have a 0.86 specificity that we should move forward, that we do think that this is sacroiliac joint pain, and let's move forward with special testing. So those points are super important. Groin pain is pretty self-explanatory. What about sacral sulcus tenderness? If you go to the area that's just above the butt, just below your lumbar spine, right there's where the sacrum sits. If you press down onto that, that's the general area of the sacral sulcus. PSIS, smaller dimples in your low back. Bring your thumbs down from there. you're in that area of the PSIS. So those three things, if they are positive or reported, or if you're experiencing these things, then it would be, let's move forward with sacroiliac joint testing as long as lumbar spine and the hips have been ruled out. Once we get into the sacroiliac joint, what tests can we use to further identify and say, yes, this is sacroiliac joint pain that we're going to be addressing? These tests, first, let's talk about the ones that are out, and not in the sense of they have a good sensitivity, but in the sense of they need to be thrown away, stop using them. Don't be testing with these tests anymore. They're palpation tests, which we talked about on the previous episode, and movement tests. So palpation and movement-based tests specific to the sacroiliac joint, really not worth using because the test properties, I guess the best way to say it, they're terrible. They're worse than a coin flip. They don't give us the information that we need to move forward with this. But to every action, there is an opposite and equal reaction. So if tests are being thrown out, then that must mean that tests are here to help us, that are here to stay and give us better information. That is the case in these 4 tests. Again, Vanderwerf and Laz's research has pointed out these 4 tests to be the ones that we're going to use, but they are stress and provocation tests. If the SI joints are at question, we need to stress the joint. We need to provoke the joint to see, is this true? Is our clinical hypothesis, is what we think is what's going on actually happening? We're going to use these tests. There's 4 tests. They are sacral distraction, sacral compression, a sacral thrust, and a thigh thrust. These are the 4 tests. We're looking at least 2 out of 4 of those are positive, and the positive response to this is that you add that stressor and it creates some discomfort. With that being said, the sensitivity is 0.88, the specificity is 0.78, likelihood ratio is a 4.0. If you're not into statistics, if these words are new to you and they seem kind of weird, that is okay. All that it means is that these tests are good. A 1.0 is the best that we can get to have really good certainty that this is what's creating the issue. And these test properties, the closer you get to 1, the better that test is. So for example, the palpation test, that was a reliability that was, or test properties that were near 0.11 to 0.53. That's worse than a coin flip. These ones are 0.86 and 0.88 and 0.78, which again, give us some pretty high likelihoods or pretty good confidence that this is what's creating this. Let's take that quick BRB break and hear a word from our sponsor, InsideTracker. We all know our chronological age, but do you know your biological age? Your biological age is at the rate of which you are aging. You can be chronologically 30, but biologically going on 50, or chronologically 80, going on biologically 50. How do you find out your biological age? Assess versus guess. Our podcast sponsor, InsideTracker, will use in-depth analysis, checking over 40 biomarkers to determine your biological age and provide an action plan for you to biologically age the way that you desire. Visit InsideTracker.com/prehab or go to the show notes and click the link, and it will bring you to the webpage to enjoy 20% off the entire store for a limited time only. All right, let's take that deep breath. And get back to the show. So let's step back. The full definition of sacroiliac joint pain. This comes from the International Association for the Study of Pain, and they proposed this criteria for the diagnosis of SI joint dysfunction. Diagnosis is described as pain in the area of the sacroiliac joint, approximately 3 centimeters by 10 centimeters inferior or below the area of the PSIS, which we talked about earlier. So again, it's going to be that area and below. If there's discomfort above that, we're more suspicious of lumbar spine. We need to rule that out first. The definition goes on to say, it is reproducible with provocative maneuvers and must be relieved with local anesthetic injection into the sacroiliac joint or the lateral branch nerves. And then my favorite part of the definition is they go on to say, although it is controversial. This area, there's a lot of controversy around it. A lot of the research will say that low back pain is the #1 disability dysfunction that developed nations face, which we completely agree with. But then it goes on to say it's because the sacroiliac joint is underappreciated and undertested. Well, let's take a step back and realize that the sacroiliac joint is not referring pain up to the lower back. For it to be diagnosed as SI joint pain, it needs to be the PSIS and lower. It needs to be beneath that area, 3 centimeters by 10 centimeters below the PSIS. So we definitely need to kind of piece these things apart and then start to bring it back together after we do some more testing. So why else is it controversial? Well, it's controversial because we've talked about this before, that our special tests really may not be all that special. They have to be compared to a gold standard. What's the gold standard test for the sacroiliac joint? Well, it's injection. It's the anesthetic injection into the SI joint area. And then the special tests are compared back to that as a gold standard. The tricky part with that is that we have seen research with injections that a person can have a saline injection, or they can actually have an anesthetic injection and sometimes have similar outcomes. So we have to start questioning too, like, how good are these gold standards and what are these tests? But anyway, if we are stressing and provoking and the person is saying, or you are saying that, yep, I'm feeling it in this area, it's in the sacroiliac joint, we can be sure that we need to move forward with some solutions. So what are the solutions of this? How do we start to address sacroiliac joint pain, the discomfort that's there? Because it is uncomfortable. It can create a lot of uncertainty. It's not great to be having. And to look at the solutions, let's visit, well, then what are the causes? Because once we know the causes, we can start to have better or more precise solutions. So we know the causes are not that the SI joint is out and it's being put back in. We know that it's not due to ligament laxity, which is a new thing. But again, we're starting to see that that is not the case. But we do see that it tends to be load management factors, and it tends to be what is happening with form closure, or another cause, which makes the most sense, is something that's traumatic, something like a childbirth, a car accident, something like that. Then we can start to rule in like a high impact force of the sacroiliac joint. But let's take a step back. Let's talk about load management. Hot topic that continues to be circulated around the NBA. We've done a podcast on load management before, so make sure you check that out so that you're getting the truth of what load management truly is, and that it's just a piece to the puzzle in a dynamic system. But load management, and let's refer back to the specific population of pregnancy, because this is starting to be looked at as the factor of progressive overload and a spike in workload that is creating discomfort in the sacroiliac joint area and the low back area. The common thought is that the first trimester, second trimester, third trimester is that there's equal weight gain throughout each of those trimesters. But that's really not the case. The first trimester, the average weight gain is about 1 to 4.5 pounds. And that's for the whole trimester, where some females may not even gain weight in that first trimester, but 1 to 4.5 pounds. Now, when they get to that second trimester and third trimester, the average weight is going up 1 to 2 pounds per week. This is a big growth period. With this happening, there's more anterior distension of the abdomen, which creates more work for those posterior muscles that connect to the sacroiliac joint and to the ilium. So this starts to make a little bit more sense as why this pregnant population is getting discomfort and pain at this point in the pregnancy, because they haven't had progressive overload. They went from minimal weight gain, 1 to 4.5 pounds in the first trimester, to now 1 to 2 pounds per week. So in that case, we need to start talking about load management strategies and probably more offloading strategies. So what would that look like? Well, you're carrying around a little bit more weight anteriorly as this beautiful baby is developing. So in the day, maybe we need to take some more rest breaks so that the erectors, these posterior muscles, get a little bit more of a rest break as they're starting to adapt to that new load, that new weight gain that is happening. The other thing with load management, kind of away from that pregnant population, is, am I doing too much of the same thing for too long? Or am I doing something too much of it too soon? So what would examples of this be? Well, we got hit with a huge snowstorm in the Northeast. I've shoveled probably 5 times in the past 2 days. That's a big diagonal pattern that if I'm not training that throughout the year and I go and I shovel 5 times, that I'm going to create some strain. And it's probably going to be in the lower back or lower in that SI joint area. So I can look back at that and go, have I prepped my movement system for the activity at hand? Or was I not prepped for it? I had a big spike in workload and now I'm feeling the discomfort in this area. That would clue me into, okay, I need to start training that. I need to get my body ready for that activity. Another piece of the puzzle we can look at, for example, is rotational athletes. If we take a golfer, for example, that is a right-handed golfer, or we can reference Craig, who came on and we did a golf episode, but he's actually a left-handed swinger. So let's use Craig as the example here. So Dr. Craig Lindell, he's a left-handed swinger. If he's been swinging this club from the time that he was 15 years old up to 30 years old, he's constantly creating a ton of rotational power in this one direction, but never is offsetting that in the other diagonal, the other direction. Well, one side can start to get a little bit overworked or developed, while the other side is becoming deconditioned, creating this asymmetry there. So do asymmetries need to always be worked on? Not always, but when there starts to be discomfort or pain, then yes, now we need to start working on that asymmetry and working in that other direction. Does that mean that Craig needs to start swinging a club in his right hand? No, but it means when he's doing some medicine ball work, that he can start doing that opposite diagonal to offset all the activity he's doing on that left side. So sticking with that example, a cool way to really look at the sacroiliac joint, and when we sit down to write our programs, whether it's the low back program, the hip program, or the core performance program, that's all in our app, we really look at these factors of force closure at the sacroiliac joint. There's some research showing that the contralateral glute to the lat on the other side, that the timing of those is actually decreased once their sacroiliac joint pain. And after a person goes through a stabilization program, the timing of those muscles normalize to that other side. Take that with a grain of salt, because is it the discomfort that's changing the timing? Is it the timing that has created the discomfort? Don't know that yet. More research needs to be done on that particular area, but it is cool to think of these different diagonal patterns that we work in. When we're walking, for example, our left leg is working with a right arm swing. So this diagonal sling across our posterior spine is all working together to create this movement. So if one side is more dominant in that sling than the other side, well, maybe there's some force leakage happening at the sacroiliac joint. Powerful muscles attach at the sacrum. We talked about this in the last episode. The lats, the glutes come over, the hamstrings have an attachment to the sacrotuberous ligament, and then a bunch of smaller muscles attach to the sacrum and come over into the hip. The erectors are coming down into the sacrum, the thoracolumbar fascia. There's a ton of muscles and a ton of fascia and tendons that are in this area. So we might want to look and say, well, what's happening in this diagonal pattern? Has the lat become dominant and the glutes become deconditioned? Vice versa, has the glute become conditioned and the lat has become deconditioned? What's happening with the groin? We tend to see this one all the time. It's called the quote unquote shotgun exercise. You're laying on your back, you have a ball or a pillow between your legs, you're squeezing this thing in. It's typically given out to say that it's putting your SI joint back in. We know now that that is not the case. That is not what's happening. But someone that's having sacroiliac joint pain might have a benefit from this movement. They might have a decrease in symptoms from this movement. Why is that happening? It's happening because of force closure. They're giving themselves more stability. The adductors are coming up and attaching from the pubic, in the front, the pubic symphysis over, down into near the ischial tuberosity where the adductor magnus is coming up. So it spans and provides a lot of stability into the pelvic floor, up into the sacrum, into the sacroiliac joints. So squeezing these muscles with a max isometric is really good for that. And we also know that isometrics helps to decrease pain in a lot of different areas in the body. So no, that's a good exercise. It's not because it's putting a joint back in, it's because it's using force closure. So we need to start addressing the force closure around this area. A good strengthening program goes a really long way. That's where we want to start. We don't want to start with injections. We don't want to start with getting a sacroiliac joint fusion surgery. You don't want to start with a nerve ablation. You want to do a really good movement program and equip yourself with the right education to decrease the fear that your SI joint's not popping out. It is strong. It is stable. You have all these beautiful muscles around the area that help to provide it with stability. Next question that typically will come up: what about a sacroiliac joint belt? What about this compression belt that goes around the hips and provides compression and seems to give this idea of stability to the sacroiliac joint? What's typically done is people will do an active straight leg raise test. And if the compression that is given to them by the provider around the hips helps with that test, then they might be a good candidate for an SI joint belt. But what does the research say with the belt versus not using the belt? and with both groups doing a core strengthening type of program. So I'm going to point you to this article. I'm going to pull it up here. It's called Effectiveness of Adding a Pelvic Compression Belt to Lumbopelvic Stabilization Exercises for Women with Sacroiliac Joint Pain, a Feasibility Randomized Controlled Trial. They had 25 women with unilateral sacroiliac joint, because remember, the sacroiliac joint, there's one on each side, so it's actually the sacroiliac joints, but they had unilateral pain, so one side sacroiliac joint pain, randomly assigned into a lumbar stabilization group or a lumbar stabilization group combined with a belt. They looked at the differences between these two groups and the outcomes. Mind you that it was a smaller sample size, but what they found is that both groups had an increase in muscle thickness of the transverse abdominis with the stabilization program. They all had a decrease in sacroiliac joint pain, but there was no difference in the group that wore the sacroiliac joint belt versus a group that didn't wear the belt. What do we do with that information? Using a belt can be low risk. There's not a lot of side effects from using this belt, but we need to use it intuitively, and we need to know the education behind the belt. Where it becomes harmful is when the person becomes reliant on the belt and they start thinking that their discomfort going away and their function improving is only because of the belt, when we know that's not the case. It's because you've gotten stronger. You've felt more safe because of this compression that's being added there. Your body's creating the outcome, not the belt. So if we want to use the belt to help open that window of opportunity to get more movement in, to feel safer, and to start increasing our workload, that is completely fine. But please, please, please do not become reliant on the belt or think that the belt is the thing that's creating the outcome. So we'll start wrapping up this episode. And the main advice that we want to leave you with on this topic to close out this two-part series that I hope that you enjoyed is that if you are dealing with sacroiliac joint pain, first and foremost, make sure that it's truly the SI joint and not something else. Part of this process is learning what's not the cause of sacroiliac joint pain. In doing that, you'll start to learn that you don't have this floppy sacroiliac joint that is moving in and out of position. You'll learn that it is strong, it is resilient, and that you're strong and that you're resilient and that you can take control of this. Equipping yourself with the truth creates empowerment, which then creates the ability to seek appropriate solutions. And taking steps towards that appropriate solution, understand that the diagnosis and education around this joint can be tricky, but the solution doesn't have to be. We recommend using the least invasive steps first, utilizing a well thought out strengthening program. Hoping you enjoyed that episode and this two-part series on the sacroiliac joint, and you feel like you have a little bit more certainty and direction with this type of condition. Let's cover the key takeaways. Key takeaway number one, we tend to jump to the most complex and invasive rationale and treatments first, but we need to pause and reflect and seek simple solutions first. Key takeaway number two, to rule in that the SI joint is the cause of your discomfort, you need to rule out all the other areas first. Key takeaway number three, strengthening and education together create solutions and empowerment, allowing you to seek appropriate solutions. Prehabbers, thank you for listening. If you know someone that's struggling with SI joint related discomfort or pain, please share this episode with them and let them know that they can take control of this. Thank you for sharing, for ratings, for subscribing, reviewing, and all that you do to educate yourself with the right information at the right time to take control of your health. All right, everyone, we'll talk to you soon.